Welcome back to the deep dive. So to kick things off today, I want you to imagine a 42-year-old woman and her severe, truly debilitating nosebleeds. They act like absolute clockwork.
Right, highly predictable.
Exactly. They start up brutally in the days right before her menstrual cycle, and then they ease up on day one. But then, because of a totally unrelated medical issue, she undergoes a procedure that shuts down her ovaries.
Throwing her into immediate artificial menopause.
Overnight. Just bam, artificial menopause. And immediately, her blood vessels completely destabilize. The bleeding doesn't just return, it multiplies, becoming this daily severe deluge.
Yeah, it's a drastically grim clinical picture, and it's actually a famous historical case study in vascular medicine. It really perfectly frames the central problem we are, unpacking today.
Which is what our whole mission is for this deep dive.
Right. We are looking at how a single hormone fluctuating in the bloodstream can literally dictate the structural integrity of the pipes carrying that blood.
Yeah, and we're looking at a stack of incredibly dense sources today to figure this out. We've got medical journals, clinical trial data, CDC reports, patient advocacy guidelines, the works.
It's a lot of material.
It is.
Yeah.
But they all circle around this one genetic vascular disorder called hereditary hemorrhagic telangiectasia, or HHT for short. So the mission here, the question we were trying to answer for you listening, is highly specific.
It's the big question.
Exactly. How does the decline in estrogen, specifically that massive drop women experience during menopause, affect the vascular walls and the bleeding frequency in women diagnosed with HHT?
Well, to understand the collapse, we really have to understand the flawed architecture to begin with. HHT, which historically is referred to as Osler-Weber-Rondeau syndrome, it's an autosomal dominant genetic disorder.
Okay, let me pause you there because autosomal dominant is, well, it's one of those very textbook terms. That essentially means you only need to inherit one faulty blueprint from one parent to develop the disease, right? Like you don't need a matched pair of bad genes.
That is correct, yeah. If you have just one faulty blueprint, your body manifests the disorder. And it affects roughly 1 in 5,000 to 1 in 8,000 people globally.
Okay, so not incredibly common, but not super rare either.
Right. And what that faulty blueprint builds is a profoundly abnormal circulatory system. Patients develop these structures called telangiectasias.
Which are the spots, right?
Yes, exactly. If you look at the skin, the lips, the lining of the nose, or even inside the gut, you see these small, delicate red or purplish spots.
And those spots, they aren't rashes, like they are malformed blood vessels sitting right at the surface.
They are. And the disease, it doesn't just stop at the surface. Patients can also develop much larger, tangled versions of these abnormal vessels deep in their internal organs, the lungs, the liver, the brain. We call those arteriovenous malformations, or AVMs.
Wow. And according to the CDC data in our sources, the core biological failure across all these malformations is the lack of a normal capillary bed.
Right, the missing link.
Yeah. For anyone who hasn't taken anatomy recently, capillaries are usually those microscopic, hair-thin vessels that act as the middleman. The arteries carry highly pressurized blood away from the heart, and that pressure is intense.
Very intense.
So the capillaries take that fast-moving blood, they spread it out, slow it way down, and then gently hand it over to the low-pressure veins to make the lazy trip back.
Exactly. The capillary bed is essentially the shock absorber of your circulatory system. But in HHT, because of that faulty genetic blueprint, those shock absorbers, they just fail to develop in localized areas.
I was really trying to visualize the mechanics of this while reading the journals, and it feels like, I don't know, like driving off a high-speed 6-lane freeway, that being the artery, and instead of taking an off-ramp that gradually slows you down, the freeway dumps you directly into a tiny, quiet residential cul-de-sac.
With the vein being the cul-de-sac in this scenario.
Yes, exactly. The sheer force and volume of the traffic flying off the freeway would absolutely obliterate that little neighborhood street. It can't handle the pressure.
That is a very apt way to look at the mechanics, actually. Because that capillary buffer is missing, the direct connection between the high-pressure artery and the low-pressure vein creates an incredibly fragile, heavily dilated vascular wall.
Right.
The vessel simply cannot withstand the sheer mechanical stress of arterial blood constantly slamming into it. So it stretches, it bulges, and it ruptures with very little provocation.
Which explains the day-to-day reality for these patients. The most common symptom, which the advocacy guidelines say affects over 90% of people with HHT, is severe and frequent nosebleeds, or epistaxis.
Yes.
Now, if you're listening and thinking, oh, well, I get a nosebleed in the winter when the heater dries out the air, no, that is not what we are talking about here.
Not at all, no. The literature describes sudden, unpredictable deluges of blood that can last for hours.
Yeah.
We are talking about bleeding severe enough to cause massive iron loss and, chronic severe anemia.
The patient advocacy sources really highlight how exhausting this is. Patients sometimes require regular intravenous iron infusions. Some even need full blood transfusions just to stay upright and function in their daily lives. I mean, it's a massive physical toll.
It is a profound burden, and the baseline for an HHT patient is this constant, precarious structural fragility. But the clinical data, and this is where we finally get to our core question, shows that this baseline fragility is not a static state.
Right. It moves.
Exactly. It fluctuates wildly depending on the patient's hormonal environment.
Which is where the medical mystery actually starts.
Right.
You have clinicians noticing that women with HHT have symptoms that change in lockstep with their biological clocks.
Yeah, women with HHT have been reporting this to their doctors for decades, actually. They notice that their nosebleeds fluctuate with their menstrual cycle. The prevailing pattern is that the bleeding significantly worsens in the few days just before menstruation begins.
Which is the exact point in the cycle when estrogen levels naturally plummet.
Yes. And the pattern becomes even more aggressive later in life. The severity and the frequency of these nosebleeds often intensify drastically after menopause, which is, of course, the point when the body's natural estrogen levels permanently crash.
So let's go back to that 42-year-old woman we mentioned at the very beginning of the deep dive, the case study published by Kokut and colleagues. This really grounds all this abstract hormone data into a terrifying reality.
It's a very stark illustration. So she was a 42-year-old with HHT, and she had that classic pattern, right? Severe epistaxis occurring routinely just before her period, which would spontaneously resolve on the first day of her new cycle.
Right.
But at age 42, she had to undergo radiation to her ovaries, effectively castrating her and throwing her body into immediate artificial menopause.
So they completely shut down her estrogen factory in one day.
Yes. And the fallout was immediate. She experienced a sudden, severe explosion in the incidence and severity of her nosebleeds. The doctors also documented a rapid spread of new telangiectasia lesions appearing on her body. Her entire vascular network just seemed to destabilize all at once.
Wow. And the only way the doctors could stop the bleeding was by giving her ethinyl estradiol, which is a synthetic estrogen. But the journals note that whenever she had to stop taking the synthetic estrogen because of side effects, the severe bleeding came rushing right back.
So the clinical evidence establishes a very clear, undeniable correlation here. When estrogen disappears, the bleeding increases.
Okay, but I'm stuck on the physical mechanics of this. I get that hormones tell the brain to change your mood, or they tell the reproductive system to start a cycle. But how does a hormone floating around in the bloodstream actually change the physical pipe? Like, what is estrogen actually doing to the microscopic walls of these blood vessels?
Well, the medical literature points to estrogen acting as a dual-layer defense system. It provides a physical shield and then, more surprisingly, a genetic rescue.
Okay, let's look at the physical shield first. The clinical papers use the term squamous epithelial metaplasia, which is quite a mouthful.
It is incredibly dense terminology, but the physiological process is fascinating. Let's look at the endothelial cells, right? Those are the specialized cells that line the inside of the blood vessels and the delicate mucosa of the nose. When a patient has high circulating levels of estrogen, the hormone actually stimulates that mucosal lining to change its physical character.
The sources mention it becomes more squamous, which means scale-like.
Yeah, think of it like taking a thin layer of tissue paper and chemically treating it until it thickens into something closer to canvas or even leather. Estrogen provokes a physical thickening of the protective skin over those superficial, fragile blood vessels.
So it's literally building a thicker wall over the fragile, bulging cul-de-sac.
Exactly. It acts as a physical barrier against the outside world. It keeps those abnormal, delicate vessels tucked safely away from the dry air, from sneezes, from the minor friction of just existing. But when menopause occurs and estrogen levels drop, the stimulus to maintain that thick, leathery shield vanishes. The mucosa thins back out, becoming frail again.
Leaving those highly pressurized, ballooning blood vessels completely exposed to the elements. The slightest trauma causes them to burst. I mean, that makes total mechanical sense. But the second layer of defense, this genetic rescue, that is what actually challenged my entire understanding of how hormones work.
Oh, it forces us to look past the tissue and drill down into the DNA of the blood vessels themselves. To grasp how estrogen rescues the genetics, we really need to understand the concept of haploinsufficiency, which is the underlying cause of HHD.
Right, going back to the blueprint analogy, we
Sure.
said you only inherit one faulty blueprint to get the disease.
Yes, you inherit one mutated copy of a specific gene and one normal, healthy copy. Because the mutated copy is useless, your body is relying entirely on the single healthy copy. As a result, your cells are only producing about 50% of the normal amount of the specific proteins that gene is supposed to make.
And the Frontiers Journal outlines exactly what those missing proteins are. The most common genes affected in HHT are called ENG, which produces a protein called endoglin, and ACVRL1, which produces ALK1.
Right. And endoglin and ALK1 are critical components of a major communication network in the body called the TGF-beta signaling pathway.
Which the sources describe as basically the master architect of the vascular system. Like, if you don't have enough endoglin or ALK1, if you're stuck at that 50% production level, the blood vessels essentially don't get the biochemical memos they need to mature. They don't know how to recruit smooth muscle cells to build strong outer walls, and they don't know when to stop growing. They just dilate and weaken.
Yes, that is the baseline deficit in HHT. Now enter estrogen. The genetic sequencing in these studies reveals something truly extraordinary. There is a specific sequence in the DNA region that controls the ENG gene. It's called an estrogen-responsive element.
Wait, let me make sure I'm getting the sequence of events right here. Are you saying the broken gene in an HHT patient literally has a built-in backdoor for estrogen to plug into?
It functions exactly like a docking station. When estrogen is present in the bloodstream, it binds to estrogen receptors. That hormone receptor complex then travels directly into the nucleus of the endothelial cell, scans the DNA, and physically binds to that estrogen-responsive docking station on the ENG gene. And when it docks, it basically hits the gas pedal.
It ramps up production.
It dramatically increases the transcription and expression of endoglin and ALK1 on the surface of the blood vessel cell.
Okay, so estrogen isn't just thickening the skin over the vessels on the outside. It's actually going into the cell's command center and ordering the factory to manufacture more of the exact structural proteins the HHT patient is genetically deficient in. I mean, it's forcing that single good copy of the gene to work double time to make up for the broken copy.
That's exactly it. It counteracts the haploinsufficiency by upregulating the healthy allele. By pushing protein production above that dangerous 50% threshold, estrogen restores the balance of the TGF-beta signaling pathway. The blood vessels suddenly receive the biochemical memos they were missing. They recruit smooth muscle, they stabilize, and they stop bleeding.
But then menopause hits.
The estrogen supply vanishes. The docking station goes empty. The chemical signal to build more endoglin goes entirely silent. The protein levels plummet back down to 50%, the vessel walls lose their structural integrity, and the severe bleeding resumes.
You know, if you're listening to this, you're probably arriving at the exact same conclusion I did while reading the stack of journals. If estrogen is both the ultimate physical shield and the ultimate genetic rescue for these failing vascular walls, why are we overthinking this? The logical step would be to just prescribe high doses of estrogen to every single HHT patient. Just flood the system and fix the pipes.
It is the most intuitive leap to make, absolutely. And if human biology were a closed, simple system, that would be the cure. But this is where the messiness and complexity of clinical medicine rears its head. Why isn't systemic estrogen the universal silver bullet?
Well, there wouldn't be millions of dollars funding ongoing clinical trials for other treatments if estrogen solved the problem cleanly. The sources point out that high-dose estrogen, like the ethinyl estradiol given to the 42-year-old woman, well, it comes with heavy, sometimes intolerable side effects.
And we aren't just talking about mild discomfort here. Patients on high-dose systemic estrogen experience severe ankle edema, significant weight gain, nausea, breast tenderness. And from a demographic standpoint, administering high doses of female hormones to male HHT patients causes profound issues, including gynecomastia and loss of libido.
But the journals emphasize that the true deal breaker isn't the swelling or the weight gain, it's the cardiovascular risk.
Yes, the most dangerous complication by far is the risk of venous thromboembolism or blood clots. Systemic estrogen at high doses actively promotes blood clotting.
And if you think about the anatomy of an HHT patient, their vascular flow is already completely chaotic. They have blood pooling in dilated veins and rushing through abnormal shunts without those capillary buffers.
Right. So for an HHT patient, introducing a medication that makes the blood thicker and more prone to clotting is incredibly dangerous. It drastically elevates the risk of deep vein thrombosis, pulmonary embolisms, and strokes.
I mean, you trade a severe nosebleed for a massive stroke. That is an impossible choice for a patient to make.
It is. Because the risks of straight estrogen were just too high, the medical community pivoted. They began exploring medications called selective estrogen receptor modulators, or SERMs drugs like raloxifene or basedoxifene.
Right.
The goal with SERMs is to selectively target the estrogen docking stations on the blood vessels to get the genetic rescue benefits, while blocking estrogen receptors in other tissues to avoid the severe side effects and the clotting risks.
But while researchers were looking into these modulators, they stumbled upon a clinical finding that completely challenged the entire mechanism we literally just spent 10 minutes explaining.
Oh, it is one of the most fascinating paradoxes in vascular research.
Okay, let's talk about the data on tamoxifen. Tamoxifen is an anti-estrogen drug. It has been used for decades to treat hormone-dependent breast cancer by actively blocking estrogen from binding to its receptors and feeding the tumors.
So if we follow the established logic here, if estrogen is the shield and the genetic rescue for HHT patients, giving them a powerful anti-estrogen drug like tamoxifen should strip away whatever shield they have left and make their bleeding infinitely worse.
Right, that is the only logical outcome based on the models. But in the early 2000s, case reports started appearing in the journals showing the exact opposite occurring in the real world. The sources highlight a 78-year-old woman with HHT who was suffering from chronic, severe gastrointestinal bleeding, and a 57-year-old woman whose epistaxis was totally uncontrolled.
And both of these women were diagnosed with breast cancer.
Right. And consequently, both women were put on tamoxifen regimens to treat the cancer.
And instead of bleeding to death from their HHT, their vascular symptoms just vanished.
Completely resolved. Shortly after initiating tamoxifen, the 78-year-old's internal GI bleeding ceased entirely, which allowed her severe anemia to reverse. And the 57-year-old's uncontrollable nosebleeds went from a daily crisis to almost non-existent.
It's incredible.
When I first read that, I assumed it was a fluke. You know, two patients with weird overlapping physiologies, but it wasn't a fluke. The Laryngoscope Journal published the results of a double-blind, placebo-controlled clinical trial specifically testing tamoxifen in HHT patients.
The absolute gold standard of clinical evidence.
Exactly. They took 25 patients with HHT and severe nosebleeds. Half were given a placebo, and half were given 20 milligrams of tamoxifen a day for 6 months. The results were staggering. Out of the patients treated with the anti-estrogen drug, 9 out of 10 experienced a significant, measurable alleviation of their epistaxis. Their bleeding dropped so much that their overall hemoglobin levels actually rose.
It is a tremendous clinical success story, but a massive theoretical headache.
Yeah.
How can both an estrogen activator and an estrogen blocker cure the exact same genetic vascular defect? The researchers behind the tamoxifen trial proposed a conflicting theory to explain the paradox.
Right. So how does the counter-argument explain this? Because right now the biology seems entirely contradictory.
Well, the counterargument looks at a completely different protein involved in blood vessel formation called VEGF, vascular endothelial growth factor.
Okay, we didn't mention VEGF earlier. What does it do?
VEGF is the biochemical signal that tells blood vessels to sprout new branches and grow. It fuels angiogenesis. In a healthy person, VEGF is tightly regulated. But in an HHT patient, because that master TGF-beta pathway is broken, the regulation just fails. VEGF levels run rampant. The body is constantly screaming at the blood vessels to grow, 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 which leads to the chaotic, tangled formation of those fragile telangiectases.
So the body is frantically building new roads, but because it doesn't have the endoglin proteins to stabilize them, it's just building millions of fragile, broken roads.
Precisely. And here is where the anti-estrogen camp fundamentally disagrees with the estrogen as a shield model. They argue that in the specific localized environment of an HHT malformation, estrogen binding to its receptors might actually be inducing the production of VEGF.
Wait, so instead of acting as a shield, estrogen might be the match that lights the angiogenic fire.
That is the theory, yes. The anti-estrogen camp believes that the presence of estrogen actively fuels the chaotic overgrowth of these abnormal vessels. Therefore, when you introduce an anti-estrogen drug like tamoxifen, you block the receptor, you shut down the production of VEGF, You stop the abnormal vessel creation in its tracks, and the bleeding stops.
Man, this leaves us with two diametrically opposed yet scientifically validated mechanisms happening simultaneously. We have strong evidence that estrogen is the vital shield that thickens the mucosa and upregulates the healthy vessel-building genes. But we also have strong trial data suggesting estrogen might be the dangerous trigger that promotes the frantic growth of those fragile vessels in the first place.
It is a biological tug-of-war, and I think it perfectly illustrates the dizzying complexity of vascular biology. The medical community is still battling out which mechanism dominates, and it is entirely possible that both mechanisms are happening at the exact same time, but in different tissue beds. Estrogen might protect the nasal lining while simultaneously aggravating an AVM in the liver.
Which explains why treatments for genetic disorders are never one size fits all. What magically heals the vascular wall in one patient might trigger a catastrophic bleed in another.
The nuance is everything.
It really is. Bringing this all back to the core mission we started with. Understanding how the decline in estrogen during menopause affects a woman with HHT. Despite the tamoxifen paradox regarding vessel creation, the data is very clear on what happens to vessel stability when natural estrogen drops.
Yes. The clinical reality for these women is a devastating double hit. The drop in estrogen removes the physical, leathery shield from the nasal mucosa, leaving the existing fragile vessels completely exposed to minor trauma. And simultaneously, deep within the cells, the loss of estrogen silences the docking station.
Right.
The genetic expression of those crucial vessel-building proteins drops below the critical threshold, leaving the blood vessels chemically incapable of maintaining their walls.
The structural integrity just collapses from the outside and the inside all at once.
Exactly. For you listening, if we step back from the specific details of HHT, I think the most profound takeaway from these sources is really recognizing the sheer systemic power of the endocrine system. We have a tendency to culturally compartmentalize hormones. We think of estrogen merely as the hormone that manages reproduction or, triggers hot flashes or alters mood.
Right, we think of it as a reproductive switch, not a structural foundation.
But the clinical reality of HHT proves that hormones are actively maintaining the physical, structural integrity of our cardiovascular plumbing on a minute-by-minute basis. I mean, they are embedded in the DNA of our endothelial cells, dictating the physical strength of the walls that keep our blood contained.
Which leaves me with a final, slightly provocative thought for you to mull over as we wrap up today's analysis. If a natural biological drop in estrogen during menopause can literally cause the walls of a patient's blood vessels to become fragile and weep blood, how might modern environmental factors be affecting the rest of us?
Oh, that's a great point. We live in a heavily disrupted environment.
We do. We are constantly exposed to microplastics and synthetic chemicals in our water, our food packaging, our personal care products. Many of these chemicals act as endocrine disruptors. They chemically mimic estrogen, or they artificially block estrogen receptors in our bodies.
It definitely raises a valid, deeply concerning question about broader vascular health.
Right. If manipulating the estrogen docking station can cure or collapse a blood vessel in an HHT patient, could those unseen everyday endocrine disruptors be secretly altering the microscopic architecture of our own veins and arteries without us even knowing? Suddenly, that perfect engineered city grid of plumbing feels a lot more vulnerable to the plastic bottle you're drinking from.
We are unknowingly manipulating the master control switches of our vascular architecture every single day.
Yeah, we've gone from a clean, abstract textbook drawing of a circulatory system to the messy, dynamic, and incredibly fragile reality of human biology. We really hope this exploration gave you a new perspective on just how interconnected your internal systems really are. Keep questioning the plumbing, and we'll catch you on the next deep dive.